So we'll get started with grand rounds. I don't have any formal announcements. Our CME color this morning will be blue, and we'll put that in the chat this morning. Up first is Dr. Jolissaint talking about managing obesity in arthroplasty.
Thanks, Alex. Appreciate that. Good morning, everyone. I apologize for the technical difficulties that we have every single week. My name is Josef, as Dr. Snow mentioned. I'm one of the PGY4 residents here, and the title of my talk this morning is Update on the Management of Obesity and Arthroplasty. As always, we'll start with a few cases. Miss HH, this is a 61-year-old female with a history of right hip pain for 5 years. She's failed all conservative management and now states that she is unable to walk for more than 5 minutes. She's medically complex with a past medical history of diabetes with neuropathy, hypertension, COPD, and she states she is getting worked up for some heart stuff. On exam, she has a BMI of 39 and a positive stench field. Here, her x-rays would show degenerative osteoarthritic changes within the right hip. Mr. HE is a 54-year-old male retired NFL player. He has right greater than left hip pain for 3 years, and he also has failed all conservative management. He can no longer do squats and is painful daily. He has no past medical history. On exam, he has a positive stench field, limited range of motion, and a BMI of 45. On radiographic evaluation, he has bilateral end-stage osteoarthritis in both hips, as can be seen here. And finally, TQ is a 28-year-old male who was involved in an MVC 3 years ago. He sustained an acetabular fracture, which was treated with ORIF. He has had progressive pain since that time and states that he now can't move. He's gained 100 pounds in 3 years, otherwise doesn't have any medical or surgical history. And on exam, he essentially has no range of motion of the hip, and his BMI is 41. Here are his radiographs, which show evidence of post-traumatic arthritis in the right hip. So according to the most recent statistics from the CDC, 42% of U.S. adults are obese, which is a sharp rise from 30.5% in the early 2000s. And the World Health Organization has declared the obesity epidemic a public health crisis, with obese individuals at a high risk for numerous diseases, including cancer, heart disease, and diabetes. Despite knowledge of this public health crisis, we've been unable to slow, prevent, or reverse the trends in obesity in the past 40 years. These charts from the CDC show the BMI prevalence in the United States since the year 1985. And I want you to pay attention to not only the map, but also the legend in the bottom left corner. As we've progressed on from 1985, the CDC has had to create a new legend, not expecting our obesity prevalence to continue to increase, but nonetheless it has. And you'll see as we get here to 2010, a lot of the southern states are, have over 30% obesity. And so, this is 30 years that we've known about this, and a lot of public health efforts were made, and it was a huge problem. And so how do you think we've fared since 2010? Well, you guessed it, we've just gotten bigger and bigger. And this is where we were in 2020. It's projected that in the next 10 years, severe obesity or a BMI of 35% or higher will be the most common BMI category nationwide. And that also means it will be the most common BMI category of our patients. So today, as I said, 42% of US adults are obese. And we just saw this as a problem that unfortunately is not going away and is getting worse. And what exactly is so dangerous about being obese? Well, it's not the simple presence of adipose tissues itself. It's the systemic effects it has on the rest of the body. The increased amount of adipose tissue leads to an increase in the amount of pro-inflammatory cytokines and adipokines, which can be seen listed here. And this increased inflammation leads to hypertension, hyperlipidemia, asthma, arthritis, which we're talking about today, as well as type 2 diabetes and the host of issues that come with it, like thrombosis, stroke, heart attack, and even cancer. In fact, obesity and the subsequent increased growth factors and hormones are linked to 13 different types of cancers. Obesity is actually the leading preventable cause of cancer behind smoking and is poised to overtake it as the leading cause of preventable cancer in our careers. And obesity is also quickly approaching the leading preventable cause of death in the world. So in a room full of orthopedic doctors, why do we care about this and what relevance does it have? Well, in addition to increased rates of less important stuff like cancer and death, increasing BMI also is associated with increased rates of osteoarthritis, which we care a lot about. Reyes et al. Looked at almost 2 million subjects and observed them for a median of 4.5 years. And they evaluated the incidence rates of hip and knee OA and found that compared to normal weight subjects, being overweight or obese increased the risk of OA at both the hip and the knee, especially the knee. Being overweight in grade 1 and 2 obesity increased knee OA risk by a factor of 2, 3.1, and 4.7-fold respectively. And they concluded the risk of developing hip or knee arthritis increases in a stepwise manner with increasing BMI. And it's not just the weight, it's not just the increased loading that causes the arthritis. It's also increased release of adipokines and pro-inflammatory cytokines, which you mentioned earlier. So the increased loading plus those inflammatory mediators cause joint destruction, which further causes release of more adipokines and inflammatory cytokines. A study done at this institution by Drs. Odom, Springer, and Fehring used a nationwide inpatient sample, healthcare cost and utilization project, and Agency for Healthcare Research and Quality to identify over 750,000 TKAs. They actually found that the prevalence of obesity in the total knee arthroplasty population is greater than the prevalence of obesity in the general population, and that prevalence is increasing. So we already discussed that 42% of US adults are obese, and that within the next 10 years, the most common BMI category in the US would be severe obesity, or a BMI between 35 and 40. And now we've seen that the prevalence of obesity is even higher in our population of total joint arthroplasty patients. As you can imagine, this creates a unique problem for any orthopedic surgeon performing total joint replacement. This problem will only worsen throughout our careers. And what kind of problems does it create? There have been no fewer than 80 published articles in peer-reviewed literature just in the last decade concerning complications related to morbid obesity. And to sum them up, more BMI equals more problems. We have some time constraints today, so I won't present all 80 articles, but I'll present some of the more commonly cited studies, as well as some newer thought-provoking literature. So in 2009, Malinzik et al. Evaluated infection rates in 8,500 arthroplasties and throughout various BMI categories and published their findings in the Journal of Arthroplasty. Overall, they found an infection rate of 0.51%. They divided body mass index into groups of greater than 50, greater than 40, but less than 50, and less than 40. They found that the associated infection rates of BMI greater than 50 was 7%. BMI greater than 40 and less than 50 was 1.1%, and less than 40 was 0.47%. And you can see those odds ratios there. With the BMI over 50, you have an 18.3 odds of getting infection over a normal BMI individual. Davis et al. Examined the effect of BMI on median term outcomes in a cohort of 1,600 patients. They underwent primary total hip replacement for OA, and they published their findings in the Bone and Joint Journal in 2011. They followed these patients prospectively for 5 years and looked at dislocation, revision, duration of surgery, as well as infection, both deep and superficial. And they also looked at outcome scores such as the Harris Hip Score and the SF-36. And they found that patients with a BMI of 35 had a 4.42 times higher rate of dislocation than those with a BMI less than 25. And increasing BMI was also associated with superficial infection and poor Harris Hip scores and SF-36 scores. Interestingly, this particular study, they concluded that despite the increased risks, which are substantial, the 5-year outcome scores still indicate that obese patients have something to gain from total hip replacement and that it shouldn't be withheld. This study at NYU selected almost 300,000 patients undergoing primary total joint arthroplasty from the NISQIP database from 2008 to 15, and they grouped them into 3 groups based on BMI. They looked at 30-day complications. They found that patients with a BMI greater than 30 had more infectious and medical complications compared with non-obese patients. And when they looked at the patients with a BMI over 40, they had longer operating times, length of stay, rates of readmissions, reoperations, higher rates of DVT, renal insufficiency, superficial infections, deep infections, and wound distance. This is all within the 30-day window around surgery. They concluded that based on this data, interventions to decrease BMI should be explored before offering any elective surgery to obese patients. This is a graphical representation of their data regarding infection and readmission. And in the days of NISQIP data and value-based healthcare, I'm sure you can see the issue with performing an elective surgery in this patient population. So in 2013, based on some of the literature I presented, as well as many more peer-reviewed articles, the AUKUS work group published an evidence-based statement on obesity and arthroplasty. They stated that despite improvements in patient-related outcome measures, as shown as that study in the Bone and Joint Journal, all obese patients undergoing total joint arthroplasty are at increased risk for perioperative complications. And it appears that the morbidly obese patients, or those patients with a BMI over 40, are the threshold for which the majority of perioperative complications, including infection and revision, appear to increase considerably. They stated that this needed to be discussed with every patient prior to surgery, and strong consideration should be given to reducing weight and minimizing associated comorbidities. Watts et al. Published a cohort study looking at revision total joint arthroplasty and the effects of obesity They performed a one-to-one matching for sex, age, and date of surgery to compare patients with morbid obesity to those without morbid obesity. And they looked at revision, reoperation, and prosthetic joint infections. And as you can see here, obese patients had a significantly higher rate of both revision and infection. They concluded that morbid obesity is associated with increased rates of re-revision, reoperation, and prosthetic joints infections after aseptic revision, total knee arthroplasty. They also added that as the time-sensitive nature of revision surgery may not always allow for patient optimization, this emphasizes the need for improving our care of patients with morbid obesity earlier on during the osteoarthritic process, aka not doing a primary joint replacement on a morbidly obese patient in the first place. Studies have also been published showing that obesity has a negative impact on clinical outcomes after total knee arthroplasty. This study out of Scandinavia evaluated 48 patients who underwent total knee arthroplasty. The patients were divided into two groups according to their BMI. They found that the obese patients had poor clinical success at final follow-up. Their WOMAC scores were significantly higher compared to non-obese, and non-obese patients reached better percentage improvement in the KSS compared to obese patients. Additionally, obese patients had worse long-term range of motion. They concluded that obesity has a negative impact on the outcome of total knee arthroplasty, assessed by patients' clinical function and satisfaction level. And you can't discuss this topic without mentioning this paper. This is the often cited paper out of Mayo published in JBJS in 2016. They analyzed 21,000 consecutive hips treated with primary total lobar arthroplasty between 1985 and 2012. And estimates of revision surgery and common complications such as dislocation and infection associated with BMI were analyzed using the Kaplan-Meier method of assessing survivorship. The results can be seen here. And as you see, they found that reoperation and implant revision or removal rates increased with increasing BMI. And increasing BMI was associated with increased rates of early hip dislocation, wound infection, and most strikingly, deep periprosthetic infection. And if you look at the hazard ratios, you can see a dramatic change from the BMI 35 to 39 group and the BMI over 40 group. And these results were what led many to adopt a strict BMI cutoff of 40. However, in all reality, BMI is a continuous variable, and this was one of the first papers to look at BMI as a continuous variable. If we lump patients into categories of 35 to 39 and then over 40, yes, we see those differences in hazard ratios and outcomes. However, is a BMI 39 really different than that of a BMI of 40? Or is a BMI 39 with the host of medical comorbidities and prior heart attacks really lower risk than a BMI of 41 with zero other comorbidities like an NFL lineman? Nonetheless, in the world of value-based healthcare, the plethora of literature regarding inferior outcomes, lower patient satisfaction, increased risk, and increased cost led many to adopt a strict BMI cutoff of 40 for patients undergoing elective total joint arthroplasty. And for many orthopedic practices across the country, due to the increased risk, the policy is to withhold surgery on patients with a BMI over 40. And it's not that you just withhold it. Many practices have policies in place to try and support these patients via a detailed discussion of the risks and benefits, as well as a bariatric referral. And for those patients with a BMI over 40 who otherwise qualify for surgery but need to lose weight, how are we doing in helping those patients? A study out of our institution looked at this. A total of 289 morbidly obese patients with end-stage osteoarthritis were prospectively followed. At initial visit, they were given information about the risks of total joint arthroplasty in the morbidly obese and were given referral information to a bariatric clinic. They were contacted at 6, 12, 18, and 24 months, and minimum follow-up was 2 years. Strikingly, almost a third of patients had no further contact with any of the health systems within the area. Only 23% went to a bariatric appointment, and only 13% had bariatric surgery. And of those 9 patients that did have bariatric surgery, 4 underwent joint replacement. Overall, of everyone studied, 19% of the patients underwent total joint arthroplasty during the study, and 30% were with a different surgeon. 7% had bariatric surgery prior to total joint arthroplasty, and you can see their BMI at initial visit and just before their joint replacement there, dropping down to almost 35. And the other 93% that did not have bariatric surgery and did undergo joint replacement, you can see their BMI there. For the over 80% of patients that did not get surgery in any form and did not come back, their BMI was essentially unchanged from presentation to latest follow-up, which you can see there. Interestingly enough, several other studies published since that one was studied have looked at these patients and published almost identical results. This one out of UNC in 2020, and this one published out of MUSC in 2021. Of those select few patients that do elect to undergo bariatric surgery, is there a benefit? I would say with regards to the comorbid conditions that typically follow with obesity, absolutely. This meta-analysis published in JAMA evaluated bariatric surgery, weight loss, and comorbid conditions. As you can see, bariatric surgery completely resolved or improved significant comorbid conditions such as diabetes, hypertension, hyperlipidemia, and OSA. For those patients that do undergo bariatric surgery, does it improve their outcomes after total joint arthroplasty? And I would say there's conflicting evidence regarding this. Numerous studies have shown improved outcomes in bariatric surgery undergoing total joint arthroplasty. McLaughlin et al. Published lower in-hospital complications and improved short-term outcomes. Watts et al. Reported decreased reoperation rates and revision rates. Kulkarni et al. Published on decreased wound infection and hospital readmissions. And Werner et al. Reported a decreased overall complication rate. However, there have been studies that report worse outcomes with bariatric surgery in total joint arthroplasty patients and question the belief that bariatric surgery prior to arthroplasty may improve the clinical outcome for patients who are obese or morbidly obese. Smith et al. Performed a systematic review and meta-analysis of bariatric surgery prior to total hip arthroplasty or total knee arthroplasty and stated that it does not significantly reduce the complication rate or improve the clinical outcome. Nicola et al. Evaluated a cohort of patients who underwent bariatric surgery and arthroplasty and compared them to two control groups, actually. One with a BMI over 40 who underwent arthroplasty and another with a BMI under 25. Interestingly, group one, or the ones that had bariatric surgery, had the highest incidence of deficiency anemia, cardiovascular disease, pulmonary disease, liver disease, ulcer disease, polysubstance abuse, smoking, as well as medical and surgical complications such as DVT, pneumonia, two-year infection, revision, and manipulation. This Frank Stinchfield award-winning paper published this year sums up the current literature, stating that morbidly obese patients undergoing total hip arthroplasty have increased risks of certain complications, but it is unclear if bariatric surgery improves this risk. Their study, similar to several of the other ones I just presented, found that patients undergoing bariatric surgery have worse implant survivorship and higher dislocation rates compared to patients with naturally low and high BMIs. And they concluded that further investigation into the post-bariatric metabolic state is warranted. So hearing all that data, can we take a balanced approach and still achieve good results for total joint arthroplasty patients in the setting of obesity or morbid obesity? Well, there is some literature to suggest that good results can be achieved. Collins et al. Looked at 633 participants undergoing total knee arthroplasty and classified them based on BMI. They found that study participants with a higher BMI had worse preoperative WOMAC pain and function scores and greater improvement from baseline to 3 months. They also found that the mean change in pain and function from 3 to 6 and 6 to 24 months was similar across all BMI groups. 24 months participants in all BMI groups had similar levels of pain, function, and satisfaction. So despite BMI differences, patients were able to achieve the same delta improvement and all had similar satisfaction and function. We've discussed obesity, common comorbidities that go along with it, and the negative outcomes associated with them in arthroplasty patients. But since we are making decisions for surgery and creating cutoffs based on only height and weight, we should evaluate how obesity in and of itself affects outcomes. Nick Giori and colleagues published a thought-provoking study in JBJS looking at this. They looked at patients undergoing total joint arthroplasty and evaluated them based on BMI group. They actually adjusted for their Charleston Comorbidity Index and age. And they found that the odds ratio of a major complication rose from 1 at a BMI of 25 to 30 to 1.37 at a BMI of 40 to 45. Or in layman's terms or absolute terms, the risk of a major complication increased 1.5% overall when the BMI raises from 25 to 40. So we just saw on the last slide that the odds ratio of a major complication is 1.37 in the setting of obesity. So how does that compare to other comorbidities that we deal with on a daily basis? Cordy et al. Evaluated over 1,000 total arthroplasties and using multivariate analysis evaluated independent risk factors for in-hospital complications. And this study found that COPD had an adjusted risk of 4.16, congestive heart failure 9.71, coronary artery disease 2.8, and cirrhosis 8.43. And these are all conditions that we often operate in the presence of. Granted, they're not modifiable like obesity. However, we do operate in the presence of them. Nick Giori and colleagues in that same study also published that if a strict BMI cutoff of 40 were used, you would deny 14 patients a complication-free surgery in order to avoid just one complication. So with all this evidence, what should we be doing with obese patients seeking total joint arthroplasty in 2022? I think a reasonable attempt should be made to reverse the risk factor, which in this setting, the risk factor is obesity and it is modifiable. However, if you and the patient together are unable to reverse the risk, you should factor in overall assessment of the patient's health to decide whether to proceed. I think we can agree that a BMI of 39 with prior heart attack and numerous medical comorbidities may not actually be lower risk than a BMI of 40 in someone that doesn't have any medical comorbidities. Additionally, you should employ shared decision-making. Present this research to those patients and decide together whether you should proceed. And finally, optimize the medically controllable consequences of obesity. So with that, let's get back to our cases. HH, our 61-year-old female, she's a BMI of 39 and a past medical history of diabetes with neuropathy, hypertension, COPD. She was getting worked up for some heart stuff, and it turns out she has an old MI with small wall motion abnormalities. She was seen by our PCP and cardiologist, optimized for surgery, and she got a total of arthroplasty. TQ, our 28-year-old male with a BMI of 41 who was involved in a motor vehicle crash and developed post-traumatic arthritis. Given his young age and tough circumstances, despite his BMI, he was the recipient of a total of arthroplasty as well. And then finally, HC, our retired NFL player with a BMI of 45 and no other comorbidities. He's come back several times and thus far has been unsuccessful in losing weight and is still awaiting a total of arthroplasty. So in summary, increased BMI does indeed lead to increased complications in total joint arthroplasty. Complications are multifactorial due to the comorbid conditions that are common in obesity. Bariatric surgery may or may not be beneficial for our total joint arthroplasty patients. We should take a multifaceted team-based approach to optimize these patients to the best of our abilities, including efforts to optimize their weight and then decide when to pull the trigger as opposed to using a strict cutoff for surgery. Thank you to Dr. Springer as well as the class of 2024, wife and kids. With that, I'll take any questions.
Joseph, how do you initiate the conversation about obesity with a family? So, and I bring it up, I had a co-resident of mine. He was, when we were senior residents, he was talking with a patient at Myers Park. And there was a formal complaint written up about him because, quote, all obese people need to be living on an island where they only eat fruits and vegetables. The conversation went along, really, he just said, well, if we're modifying some of those other risk factors, but how do you kind of initiate that conversation? It clearly isn't always well received. You have a lot of patients that we've shown even here that don't seek any other further assistance here, with only a third of those patients even coming for any further assessment and some going elsewhere. So how do you initiate that conversation?
Yeah, the way I've always found to initiate it is I leave it very open-ended. If I know the patient has a high BMI, I walk in the room and I just say, like, tell me about your weight, right? Because sometimes you may have a patient with a BMI of 41, but they've lost 100 pounds in the last year. And they're coming to you like happy that they've lost weight, excited because they're thinking they're going to lose more weight and qualify for a surgery, or they may not even know about the cutoff. But if you just go right to them and say, you're fat, like that's going to offend them, right? So I usually say, tell me about your weight, because then they'll tell me, oh yeah, I've been struggling for years, or I've lost 100 pounds, in which case you can congratulate them. And then you also need to show that you care about them. It's, we're not withholding surgery. If you present the literature and say, look, like, you're my patient and I want you to do well, there are increased complications with a BMI over this, and I want to get a good outcome for you because I see that you're in pain. And so I think when you present it like that, showing them that you care about them and you want them to do well, is a little bit more received than if you just tell them they need to go lose some weight.
Yeah, I can expand on that. And I think you summed that up. But the study that we did was a real eye opener for us in how we were approaching these patients. A couple of things I found is that, number one, we're oftentimes as orthopedic surgeons the first people that are addressing their weight with them, amazingly enough, right? Their primary care doctors, for various reasons, may not discuss it. Some are very good and some just don't want to deal with the thorny issue like you talked about. And so we're oftentimes the first providers to address it with them, which gives you the opportunity to make a really big impact on them. Approach it as being a team approach. And I think initially, prior to this study, we created a very adversarial environment, which was your BMI is 45, go lose weight and come back when it's below 40, right? And the data that we showed was that they don't. Number one, they can't lose weight, they're offended and they don't come back. So they need resources, just like anybody that comes into your office that has uncontrolled diabetes, coronary disease, things along those lines, right? You're sending them to an endocrinologist, you're sending them to a cardiologist. So we created this program with the bariatric group in town. We have information that's printed up. We hand it to them. We talk to them about the risks of morbid obesity and joint replacement. We make a referral. They will have a touch point with them within 48 hours. They actually have a navigator that will reach out to them. And the key is you don't just tell them to go lose weight and come back. You outline what the issues are, and you have to have multiple touch points with them, whether it's, hey, let's bring you back in 3 months and see where you're at and see what progress you're making, give them goals. I have some patients that I'll say, let's book your surgery 4 months from now, and I'll bring you back in 2 months and we'll see where you're at. Try and give them kind of a carrot, to work for, if you will. So it's all about, I think, how you approach that patient right off the bat. Because if you're adversarial, you've lost them.
Awesome. Thank you.
I had a question. This might be more for Dr. Springer, but a lot of this data is from large databases, and we don't know who's doing the surgery and all that. And I think the study from here showed that 30% of people end up getting a surgery from a different provider. I just wanted to see what your thoughts on, there's kind of all this talk about centers of excellence and all that on just doing the surgery on patients that have a BMI over 40 and knowing that, hopefully their complications might be a little bit mitigated by being done at a center like this. It's high volume versus sending them out, having, whoever do it. Just
Those average.
I think you're right. I mean, I think for a lot of patients, this is probably true for any condition. If patients really want surgery, they'll find someone that will do it eventually, right? If they go around and see enough, if they go around and see enough providers, someone will ultimately do it. And it's hard to tease out the quality. That the bigger challenge is when you look at bariatric surgery, because bariatric surgery is such a huge spectrum of procedures that are done, right? Initially, it was the true bypass surgeries, the Roux-en-Y bypass, and those patients became severely malnourished really quickly, and it took them over a year to recover a lot of their metabolic functions. And now most people are getting gastric sleeves, and they don't get this micronutrient deficiency that we saw with some of the true bypasses. They don't lose weight as rapidly, but it's probably a little bit of a healthier, weight loss. And when we look at the bariatric studies, all those tend to be lumped together when they're actually very different, I think, in their outcomes. But I think you're right, in large database studies, you can't really tease out the quality of the individuals that are doing the surgery, because it's just not that granular enough to be able, to know that data. So, I think our approach has changed in that if we can, as Joseph nicely outlined, if we can appropriately get their comorbidities under control, am I okay with doing someone that's 41, 40? As long as those patients understand that they are at higher risk compared to the normal population. We don't really know if obesity is a true modifiable risk factor, right? It's kind of like smoking. If you smoked and you quit smoking, your risk never goes down to someone that's never smoked before, right? You're still at an intermediate risk. And obesity is probably the same way. If you drop your BMI from 45 to 38, you have probably dropped your risk, but it's probably not to that of someone that was never morbidly obese.
Do you know if there are any studies looking at what makes the people who are successful in losing weight and then ultimately getting their total knee or total hip done? What about them makes them successful? Is it that they have more psychological hardiness? Do they have more financial resources? Do they have better PCPs who are fellowship trained in preventative medicine? What is it about those people? Because they seem to be the zebras in this scenario, right? Are there any studies out there on that?
I didn't come across any, but that's really a great question. And I think, the people in that particular study that did end up undergoing it with, as Dr. Springer mentioned back then, how we were approaching it, go out and lose weight and come back. Those probably were the hardy individuals that, kind of had a motor and knew what they wanted and went and got it. And obviously we don't have a study to prove that, but I think taking the multifaceted team approach is trying to make it available and accessible and possible for maybe people that aren't like that, right? Touch point in 48 hours, right? That can change a lot of people. If they feel like someone's invested in them and losing weight, they may actually go rather than just those 20% of people that end up going.
Right, and I wonder if adding, fellowship trained primary care providers in preventative medicine to that interdisciplinary approach would be helpful because that's what they do all day long. So maybe,
Absolutely. And I think there's not all obesity is the same, right? I mean, there's clearly those patients that have been obese their whole life, and it's a genetic issue, right? They've been, unfortunately, genetics and various reasons and other diseases, they've been morbidly obese their whole life, as opposed to someone that has, gained 150 pounds during the pandemic or something like that, right? Those are probably two very different risk profiles of patients, I suspect.
Awesome. Thanks everyone for your comments.